Thank you for the moment of silence to recognize those in different conflict areas and also the ongoing challenges in Africa, Haiti, and Gaza. Thank you. Back to Global Public Health Week. The Global Public Health Week is quite an important week. It reminds us in terms of the different challenges that we're facing as the health community and also allows us to look at different ways to address them. For Africa's context in South Africa, I'd like to take a piece from history to remind us about the importance of us meeting together to try to work to achieve rebuilding Africa and also the global village as a whole. And I want to go back to the Roman times in 146 BC. And that's during the time of Carthage, the great city and the great empire of Africa, the greatest in terms of histories, recognizations. And basically there was a Cato the Elder who was from Rome. And whenever he used to make speeches, he always reverted back to Carthage, Asse Daladam, which says otherwise, Carthage must be destroyed. And eventually Carthage was destroyed in the Punic Wars with Scipio. And why is it important to remember this? Carthage is one of the empires that had brought Rome to its knees as an African country with different technological advancements in warfare and other different cultural aspects that helped support it to build such a great city. And we need to look at this week as the beginning of those conversations to rebuild the current Carthage for Africa. And that will, for us, will be contributing towards improving the health of our people. This has been echoed by many philosophers within our history, such as Nelson Mandela, where he said health cannot be a question of income, it's a fundamental human right. And also Kwame Nkrumah from Ghana, who had said that the welfare of our people is our chief pride, and that is by this that my government will ask to be judged. And we need to, one, work together during this week to remind of the different ways we can work together to rebuild our own health as a country and also as a region, and rebuild our Carthage. And also to remind those who do responsible for government to know that health is quite important and is one of the main things we can be able to judge some of the outcomes of what they do. And so I implore you to please do attend these different events that we're having during the week. And in your mind, have that concept and that understanding that we're all working towards one common goal, which is to see Africa where it should be and improve the health of our people. I will not take much more time as I know you're excited for this topic that's about to happen. And I'd like to thank everyone and remind them to please remember that we are trying to rebuild Africa and the health of our people and also the global village. Thank you. I'd like to hand over to Natisha, who will now kick off this webinar. Thank you so much.
Thank you so much, Lwando, for those great opening words. It really sets the scene for today and this opening session, which I'm sure you're all excited to be here. We have a good amount of people joining, and that's great to know. I want to kickstart this session, but before I do, just some housekeeping rules is that you will see from time to time I'm always muting people who are not speaking as part of the panel. And that's because we don't want interference of the session. We do have, a set session and we'd like to keep to time. So I will be muting you if you're not speaking at that given time. I want to start off the session by introducing our keynote speaker for today, Prof. Norbert Ndjeka, and a little bit about him before I do hand over to Dr. Ndjeka is that he's a specialist family physician with an interest in TB and HIV. And currently, Dr. Ndjeka serves as the Chief Director, TB Control and Management at the South African Department of Health. Dr. Ndjeka has been involved in with various organizations. He has served as the WHO temporary MDR TB advisor. He has been part of the TB team experts roster as an experienced expert in MXDR TB. He has also worked at various hospitals in South Africa and outside South Africa, having received degrees from the University of Congo, University of Witwatersrand in South Africa, as well as a diploma from the College of Medicine in South Africa, as well as being associated with the University of Limpopo, having a master's degree in family medicine. So I'm now going to hand you over to our keynote speaker for today, and that is Dr. Norbert Ndjeka. Dr. Ndjeka, over to you.
Thank you so much, Natisha, for introducing me. Colleagues, I want to discuss rethinking public dams. Let me quickly load my presentation. I'm not sure, can you see my screen? I hope you see my screen, right?
Yes, we can see your screen, Dr. Ndjeka.
All right, thanks a lot. All right, so this is my presentation really, rethinking public health paradigms. So I'll take you through a short introduction and then look at the HIV and TB burden in South Africa and globally to some extent. And then I will look at the response, but then look at the paradigms, focusing a little bit on TB, although you're going to see that we have similar challenges for both diseases. So I'll then conclude later. So as a word of introduction, I'd like to say that as early as 1986, community participation, applied behavior analysis, and ecology were identified as the most important public health paradigms to address public health challenges of the time. These three paradigms imply working across disciplines and with population itself in defined variables, designing instruments and collecting data that reflect the ecological reality of life in that population.
But essentially, the principal factor analysis is quite similar to.
So the question remains, which public health paradigms are relevant to address future public health challenges in our country and beyond? So this presentation is an introductory session that is part of a week-long event that aims to facilitate robust discussions on how to strengthen communities, leading the implementation of health promotion and disease prevention, care and support in line with South African strategic plan and public health policies. But the talk will be more around the HIV, TB, and STI national strategic plan. While WHO defines health as a state of complete physical, mental, and social well-being, not merely absence of disease or infirmity, we learn from Charles Edward Winslow that public health is the science and art of averting disease, extending life, and supporting physical health by way of systematized public effort for the hygiene of the environment, control of community infections, education of individuals in ethics of personal hygiene, and the organization of medical and nursing services for early identification and preventive handling of disease, assuring conditions under which people can be healthy. This is quite long and quite tricky, but let's see how we unpack this moving forward. during the weekend, I came across this diagram from a colleague who was really presenting the fact that public health is very broad. Now, if someone would ask, what do you guys do in the public health? It is really very broad. You can see this diagram will really highlight key issues around assessment, policy development, assurance. But when you try to unpack, you see the question of investigating disease, diagnosing, treating is where we spend most of our time. But public health is broader than that. It's about communication. It's about strengthening, mobilizing communities. And it goes further, as you can see. Assurance is critical. People will trust the care they get, they'll be assured they can say, as you can see, essential public health services. I will not go to the details. I'm speaking to an audience that is really very much aware of these things. So I will skip, but this is really critical. Now, when you look at HIV and TB, we are governed by the National Strategic Plan, and you can see the main goals of the NSP in terms of breaking down barriers to achieve solutions. It talks too much to what we believe in as public health physicians. Maximize equitable and equal access to HIV TB services, build resilient systems, and provide resources, sustain efficient, revitalize inclusive and accountable institutions. Now, what we've done for TB really is to look at the main goals that talk directly to tuberculosis from the NSP, as you can see, strengthening community-led responses, strengthening diagnosis, linkage to care, support, accelerate scale-up of innovative processes, all these key objectives from the NSP. We drafted a TB strategic plan that really is focused at what we do in government, because the NSP is what everybody does in the whole country. So this is now a better way to begin to say, let's focus at what we're supposed to be doing in the government facilities. Of course, it doesn't mean we dissociate ourselves from what other people are doing, but improving internal and external communication is critical. We want to increase the number of people, we want to find TB to end TB. So our pillars directly from the NSP become then communicate and advocate, find and link, treat and retain, then prepare, monitor, and assess. So this to us has been a new way of looking at our response to the major challenge that we've been having over the years. And you'll see in terms of the response later, what are we doing about this? Now, in terms of the burden, we know that we achieved the first 95 as a country in terms of HIV. So most people who live with HIV know their status. But the problem is the second 90. We only have a certain number that is on treatment. Is lower than 90% or 95%. So we have a challenge in terms of the second and the third 95. And you can see with our HIV program, case finding is a problem, poor linkage to care, gaps in treatment initiation, high loss to follow-up, and treatment interruption. When you look at tuberculosis, we high burden. Close to 300,000 people have active TB every year in the country. Now we have 54% of our 2022 cohort will be made of people living with HIV. Yes, we've increased the treatment coverage to 77% for the first time, but we still have low, high treatment. Death rate is still high. Lost follow-up still very high. Now, if you look at the gaps here for TB, the incidence is coming down, case finding is improving, but we still need to reach 90%. We're still way below 90 or 95%. And COVID has done something terrible to humanity. So when we talk about paradigms, a lot of the things that I'll be talking about later indicate really how we've responded, how we've taken into account COVID, because it exposed us. As you can see, we had a decrease, significant decrease in case finding and even testing. So they've been really a challenge there. And when you have a challenge like this, you have to now change. You have to change your way of thinking, the way of doing business. Otherwise, you go out of business. So the mortality, I indicated a big problem, but here I chose this slide because it really indicates our thinking. We're more biomedical, because if you look at this, it tells me that TB deaths came down, the numbers came down due to introduction of antiretroviral therapy. But now if you look here, your people who are HIV negative, death rate is actually slightly increasing here. So because we are just biomedical, we believe in giving pills. We think the pills are solutions to everything. Now we're experiencing this challenge. And that's why I think having a reflections we're going to have this week will really help us to think about what can we still do. You know, we have better regimens, new drugs, ARVs, better TB drugs for MDR TB, but we can't decrease. I mean, if you look at this one, they've been very little decrease, but ARVs have done the big job there. So it's really the way we think. It is to do something with our thinking, what to prioritize. Now, when you think about the HIV challenges, look at the TB, same, low case finding. We have a lot of missing people, particularly among children. Adherence is a problem. Loss to follow-up is a challenge, still high. Mortality is still high. So I would say that the two diseases have similar problems. Now, in terms of response, pretty much the same. We're increasing number of people living with HIV. We've increased people on ART. We've increased those with viral load suppressed. Very good. But like I said, we still have to reach our 95 around that. Now, what are we doing about TB? No, we still have HIV. Just to give a snapshot, we need to enroll 7 million people on ART. We still at close to 6 million. So we prioritize the number of activities to reach that goal. For TB, we have transformed the NSP into the TB strat plan, and we write a recovery plan every year to guide, to really show what is priority from your strategic documents, which is something new. We've been making effort to do the test to find TB. It's working quite well. Again, we're very biomedical. We succeed in testing. We treat a lot of people. We really achieve our targets in terms of notification and treatment. But when you look at issues of prevention, we're still lagging behind. But this is progress. is good progress. But what is interesting is that in terms of those that are missing, if you look well here, you find adults 65 years plus. We've been saying the males, but it's not really just the males. It's your 65 plus, your males below 35, and children below 15. These are your major groups that are really missing. And in terms of the response, then you have to consider these categories. Of course, our TB cascade has improved, but like I indicated, we still have gaps that we have to achieve. Now, looking at all this, our plans, our response and all that, when I look at rethinking paradigms, what came to my mind first was the very WHO bold policy from 2015 in terms of ending TB. So I want to focus more on TB here because problems are similar, and you can see TB requires really a lot of work. Now, when you look at the WHO policy here, this was really something different, because then you begin to move away from your old stop TB, your DOT strategy, DOTS plus, and all those things, you know. This is something good because it's looking at putting a patient at the center of everything. And we now monitor then these three indicators. I'll not go through all the details, but I thought this is something very good, because even for COVID, what we noted was good implementation of those guidelines that existed from WHO, from CDC, helped us deal with the problem. For the first time, we had everyone start to say to government, to politicians, listen to the science. And we put the science through WHO, because WHO is all of us. We contribute from all the countries. And when it is put, we don't follow. We didn't follow in the past. So this is something I thought which was very, very interesting. Now, when you unpack this WHO policy or recommendation, you see that it is really patient-centered, and this is endorsed in our constitution. The right to care, you know, it's something that talks to our constitution. The Batupele white paper, again, is in line with this recommendation. And South African healthcare workers perceive patient-centeredness as an awareness of the importance of patient culture involving the patient's family, incorporating values of love and respect, optimal communication in all facets of patient care, and accountability to the patient, and acknowledge the importance of family participation in patient-centered care. So this is something international, but it talks to us. So our priority within the TB program and the National Department of Health, if you look at the focus, areas of focus, which are rapid access to high quality diagnostics, treatment and support. All these are big priorities that that are aligned with the international thinking, but also a new way of thinking, because we begin to say that intersectoral advocacy is important. Wider use of screening and testing, very, very important, and all the issues regarding quality care, provision of treatment and psychological support. So these are the priorities that we're looking at. But more importantly, which is really very much linked to what I'm saying now to our response, is a prioritization of impactful interventions. In the past, what we did was really to have a book, and we tried to do everything in the book, and then we lament we didn't have the resources. Now we're very clear. Want to accelerate reduction to decrease incidence and mortality. Want to find TB, for example, and TB. If you look at HIV, it's the same. We've got to put more people on treatment to cut down the chain of transmission. So it gets really clearer that this is where we're going, but we can't do that without quality care, without data systems, which we are still struggling, but we're moving in the right direction. So I thought that maybe one of the examples I could use to show, again, the shift from our side is the social behavioral change communication. We want to invest more around this aspect, want to create demand for TB testing through advocacy and communication. Hence, we've invested a lot of our time and resources, and we'll continue to work around this. We believe that if we do this, we'll be able to get our numbers. We'll be able to do a lot of, we'll be able to implement our plan. This is our annual plan. You can see it is focused. It is really looking at what is going to give us more results. So I thought maybe it's a good example to show a new way of focusing at a problem, but also bringing in elements that were not considered as very important in the past. So this is a strategy to guide effective communication, to improve TB knowledge, support improved help-seeking behaviors, reduce stigma, and strengthen linkage to care, change in order to achieve goals and objectives of our TB recovery plan, which come from our NSP. So we're working on a toolkit that will accompany this. But I think what is critical is to really go back to the fact that communities that are affected have the right to meaningful engagement, and wanting to cover that, want to make sure that people, to ensure that people have right to social determinants, and the plan takes care of that, as well as being gender sensitive. Now, I will not waste a lot of time on this, but just to say that the determinant of behavior, as you can see, in terms of knowledge, attitude, beliefs. So we incorporate this more carefully in our policies, in our plans, in order to achieve successful diagnosis and treatment. And you can see the type of people we meet to achieve this. We've had meetings with traditional leaders. If you want to ask me about it, traditional healers as well. I'm not sure we met enough, but we want to exhaust this list moving forward, because we have the interests of our community at heart. Now, when you look at our plan, what we've also done was to look at our pillars and say that, for example, advocacy, communication, and social mobilization will do for each pillar to achieve, for example, demand for testing, to help us increase numbers on treatment, to help us establish linkage to care. We're doing that, and we find that multi-sectoral engagement, as indicated from the previous slide, works for us. We start to see some fruits. Of course, it's critical that we get improvement of knowledge for TB, awareness, the rights, and all the objective, the benefit you see here. I think I'm preaching the converted here. I will not really dwell too much on this, but you see that communication is something we haven't done very, very well. These slides indicate what we want to do in terms of the end TB from WHO. They talk about early diagnosis. What does it mean for us? What do we need to do not from diagnostic perspective, but from our advocacy, communication, social mobilization unit. So these are the issues that we are going to we started to do this and want to invest more time around this. I've spoken about this. I'm just repeating myself to show that these are very important aspects. Patient-centered approach is very, very important. Again, information provision, demand generation for TB services are critical for us. And they've been, now these are the functions. We want to inform, want to use persuasion when we talk to our people, and social support, enabling environment. So all these are linked to each pillar and objectives of our plan. And we've also hired people with the knowledge, with expertise in this area to assist us to achieve some of these objectives. Traditionally, we only did posters, but want to do more than just serving posters or TV. But the good thing, though, is if you look at the posters, in the past, we relied on partners bringing them to us. Now, we design this in-house, and we feel the message is really talking to us. We like the kind of message. For example, this poster is around the SMS. We want to make sure that that people provide their cell phone numbers so that everybody tested for TB in the country get a SMS to tell them you got TB or you don't have TB. Again, learning from COVID experience. So the barriers are really numerous in terms of in the individual level, family, community, and structural. So we are hoping that with the plan I've just explained now, we'll be able to.
Okay, let me go on with that. I can't hear him.
Sorry. All right, so this is my last slide. Communication channels. We believe that we need to exhaust all communication channels. We haven't used much of the social media. We know our young people use this, and they are part of the group that is missing. We've been struggling to really deliver SMSs to everybody. We just reached 40-something%. And perhaps if we do WhatsApps and improve, we'll be able to reach more people but still augment on the traditional methods. So, but the change agent as communication channels should be your healthcare providers, so TB ambassadors. We introduced the 6-month regimen last year in September for MDR TB. And we got some young people to come and talk to us during the symposium we organized on the 23rd of March. We got a few young people, 3 young people cured, put on treatment last year, September. And it turned out that giving them the opportunity to speak to healthcare workers became the highlight of the event. It was really very interesting to see that the physicians in attendance, all healthcare workers were very interested to hear what the patients were talking about, their experience during the disease, and they showed that they're grateful that they've been treated for 6 months. And they know that used to be 2 years. The one patient said his father was MDR TB a while ago, had a long treatment with injectables and all these things. But we also have to work with civil society organizations. They are the one that should really help us take this, drive the plan into the community. We also want to have more contacts, more meetings, TB caucus in the provinces so that we have this. So this is really what I have to offer here. And just to end that, in addition to community participation, applied behavioral analysis, and ecology, there are other paradigms. We need to think about prioritization of impactful interventions. I've given some examples. We've started using, and we see some benefit, focus on patient-centeredness, multi-sector accountability, but also preparation for unplanned situation. I'm looking at beyond pandemic preparedness. We don't prepare. And the use of technology is critical. Artificial intelligence is helping us. We're using digital chest X-ray with AI interpretation. It's really helping us to find people with TB. It can help with other conditions as well. Also have to address barriers to care at all levels. So I will leave you with a quote from Nelson Mandela here, who says, after climbing a great hill, one only finds that there are many more hills to climb. This is really our situation. We do all these things, and then we find more problems. You give shorter regimen, you bring bedaquiline, you improve success rate for MDR-TB, then resistance to bedaquiline, the best drug, is increasing. And all, so we come across these challenges now and then, but we need to continue working very, very hard. I thank you for listening.
Thank you so much, Dr. Ndjeka. I think that was really thought-provoking. I love the way you especially touched on communication. That seems to be, a relevant problem, especially around communication regarding health and health disparities in South Africa, especially, and I'm sure it pertains to other countries as well, because we have a diverse audience. But speaking to it from a South African perspective, you gave good insights into how communication is not just a single layer, and that there are several layers to it, and how we actually involve the various stakeholders, the interplay of the various stakeholders at each level, and how we can get them, to commit to that level of collaboration and going forth. I'm now going to invite a panel to join you, Dr. Ndjeka, for the Q&A session, and part of their reflections. They've heard you speak, and they've had time to reflect, time to think about what has been said and what they would like to share with us today. So I now invite the following 4 panel members to join us. If you can unmute and also put your cameras on. I would like to take the opportunity to invite Dr. Tumelo Assegai, Dr. Ndumiso Tshuma, Dr. Ishak Date, and Prof. Takalani Tshitangano. If you could please join Dr. Ndjeka during this panel discussion. We've prepared some questions to ask you along the way, but before we do so, it would be great if our panelists could introduce themselves briefly. So in no particular order, but according to my screen, I see Ishak, you are first. You may please go ahead.
Thank you so much, Natisha, and thank you so much, Prof, for that a very insightful talk. I'm Ishak Date. I'm a specialist physician, and also teach health promotion at UCT, and I'm also part of the PHASA health promotion SIG. Very insightful. I think there's going to be a lot of good talk and discussions that will come out of this talk.
Thanks, Ishak. I'm going to now hand over to Tumelo.
Thank you very much, and thank you for having me. My name is Tumelo Assegai. I'm at the UCT School of Public Health in the Division of Health Policy and Systems, and I teach Introduction to Health Systems. And I'm also the incoming chair of the PHASA HPSR SIG. Thank you. And thank you for the talk that was just given. Thanks.
Thanks, Tumelo. Ndumiso, please go ahead.
Good morning, colleagues. My name is Dr. Ndumiso Tshuma, and I must acknowledge Prof. That was quite an insightful a presentation. It got me thinking hard around the work that you are doing in the TB space. My name is Dr. Ndumiso Tshuma. I'm a public health specialist at the Best Health Solutions. And I look forward to great engagements during the course of this session. Thank you.
Thanks so much. Last but not least, Takalani.
Thank you so much, Natisha, and thank you very much, Prof. Ndjeka, for this insightful presentation. We learned a lot. You really gave it your all, and we appreciate all the information. My name is Takalani Tshitangano. I am from the University of Venda, Faculty of Health Sciences, Department of Public Health. I teach health promotion. I look forward to all these discussions. Thank you.
Thank you so much for those introductions. So colleagues, now that you have heard Dr. Ndjeka and that wonderful presentation and you've had time to reflect, can you please share with the audience your reflections after this session, especially as we speak to the theme for today, which is rethinking public health paradigms. So, can you share with us what do you think effectively could tackle future health issues both at the national level and globally? Which paradigms would work and what do you think would be most useful? You don't have to really answer the question I've set out. It's for the alignment of the theme, but I would like you to share your thoughts on this session. So I'm going to go in the same order again as your introductions. Ishak, if you would like to start the reflections.
Thank you so much. I think there's a lot of great thoughts that was expressed through the talk, and I just want to maybe highlight a few things. Just looking at the definition of public health, and it seems to be that there's an evolving definition or understanding of what the role of the public health practitioner is. So, traditionally, public health specialists deal essentially with upstream determinants of health and exclusively. And the question is, is it possible for public health practitioners to be thinking both downstream and upstream? And specifically, a big aspect of what public health practitioners do is about gathering information, and a kind of a shift in paradigm towards advocacy is perhaps something for us to be thinking about. So that's the one point, and there is kind of some shifts in literature, the Global Charter for Public Health that alludes to that. But the other point that I wanted to kind of raise is, we've got TB, and we know that there are many social determinants of health that are related to the kind of intergenerational ongoing high prevalence of TB within certain communities. And so the question is, as a public health kind of fraternity, we often, we're very focused on a specific area of research. How can we expand so that we are including those other social determinants of health that are quite complicit in the high prevalence? So if we just take TB an example, overcrowding is a big challenge, and overcrowding is related to poverty. And so, if we're thinking about addressing TB, we should perhaps also be thinking about how do we address poverty, which has so many different branches. And I think that there are ways in which, using all of society approaches, we can potentially address that. And just one other point I want to put out is with regards to kind of community engagement. And so, the paradigm perhaps we should be thinking of, often we're thinking when we engage with communities, we consult with them. But how do we move from just consulting with communities to actually empowering communities towards a change as such, to be drivers of change and drivers of decreasing not only TB prevalence, but other challenges that cause our communities to have very poor health indicators.
Thanks so much for that reflections, Ishak. I'm going to now hand over to Tumelo.
Thank you very much. So my thinking is that public health is often seen as a separate set of activities away from healthcare, which is the totality of organized social actions in response to the occurrence of disease and disability and for averting the risk to health, and is given less attention or priority than clinical care in terms of resourcing, particularly in the formal public sector. And in the South African context, our lingering history of segregation, prevailing social ills such as poverty, crime, and related NCDs, how do we then respond to these complex health-related challenges, particularly in the current climate of limited resources, bad economy? So these call for a more focused, inclusive healthcare activities within a health system that prioritizes public health and infusing these public health activities within clinical care, primary healthcare levels, and at community health systems. So these can all be realized if they are done within a system or using a systems thinking view or approach. An example is that the HIV and TB and NCDs examples are teaching us that working within vertical programs and funding and resourcing them as such is costly and has not yielded desired outcomes, and certainly not sustainable as we continue to witness. And we've seen with the recent pandemic, the COVID-19, working as a health system and not as programs, where all sectors and the networks that were formed, essentially working as a whole, work to contain the pandemic in the country. Therefore, recognizing that public health and clinical care operate within a health system as a platform, and using that frame to prevent and promote health will allow us to have a more focused and shared worldviews of the problems that the country is facing, and to formulate contextually relevant solutions, but also will also allow us to have more effective and efficient mobilization and use of resources. Still in line with the system thinking perspective, another thought is that we need to have a more people-centered approach beyond patient-centered ideology that recognizes that all people as clients and providers of the health system also need to recognize, and we also need to recognize that the networks and relationships, the values and beliefs that exist within the systems and how that influence the ecosystem of the health system and diseases is important. This includes recognizing that all voices and bringing all those voices to the table and allowing everyone to have a say in how health is to be maintained or achieved. It includes more realistic and inclusive public health approaches to the idea of decolonization as an example, in terms of how we teach, how we do research, how we recognize and bring alternative healthcare approaches on board. And this can include spiritual, religious, indigenous knowledges, traditional aspects of healthcare, also improving health literacy among populations and allowing individuals to have more agency about their own well-being. And in summary, this calls us to move away from these biomedical practices, as Prof has said, but a more inclusive whole system approach to practicing public health. And this is bringing disciplines such as social behavior, environmental health, AP, health promotion, etc., together and recognizing them as interdependent and interrelated elements of the health system and implementing them as such as researchers, policymakers, and practitioners. So those are my thoughts, and thank you for having me once again. Thanks.
Thank you so much for that, Tumelo. I'm going to now hand over to Ndumiso.
Okay. Thanks a lot. I think from my side, like I said, while Prof was talking, it got me thinking, and also as other colleagues, Tumelo just articulate some of the key aspects that I think that they are very important going forward. When it comes to how we address some of the public health challenges that we are presently facing. And key in all of this, I think from where I'm sitting, it's around issues to do with communication and advocacy, particularly at a grassroots level. Talking communication and advocacy separately from a point of saying that we need to come up with means through which we communicate health information in such a manner that it appeals to the end user. Communities need to take a leading role in tailoring the messaging that we are using at a grassroots level. In terms of how we coin the TB messaging, how we coin the HIV messaging. Gone are the days when we would talk about the scare tactics of saying that if you do this, then this is going to happen to you. If you do this, then you're going to die. If you do this, then this is going to happen, because people have seen people who have HIV and TB and have not yet died. So there is a part where we go back to those same communities and have an in-depth understanding in terms of what could potentially drive behavior change. I always give a typical example of saying that if you are to look, say, amongst a certain population group, you would find that there could be, let's say, low uptake of condom use. But if you jump to another population group, which is of healthcare workers, and then you do a similar census or a similar study of saying, look at the last 3 people that you would have indulged in a sexual activity with. Did you use a condom with those last 3 people? And you would find that those statistics would not be the same as if you were asking within a key population group. And it begs to say that potentially it's not an issue of information and education. What else could be the issue when it comes to rethinking our messaging, rethinking our communication of health information? Because definitely it's not so much about the message, the information, that people lack information. It is true that there is a lack of information in some areas, but that is not the whole truth around health communication. There is something much more deeper than the information. Because if that was the case, we'll be having a situation whereby there would typically be low prevalence among healthcare workers. There will be low prevalence of non-communicable disease, low prevalence, low incidence among those particular groupings. And for those that will have gone to university, there will be lower prevalence amongst those, and then we would then be saying that this disease is a disease of those that are less educated and less informed. So with that thinking in mind, it goes back to pillar number 1 that Prof spoke to, and social behavior communication strategy, to say that, yes, we have got a social behavior communication strategy. But like as Prof said, to say that these need to be patient-centered, they need to be led by the communities. We need to have that community-focused approach and gather information from the communities so as to inform decision-making, so as to inform how the messaging tends to be coined. Because you would find that there is a need for us to recognize that the present problem is not fully captured in its roots. We are not going down to the root cause of those particular problems, which often stems from human choices and consciousness. So there are those elements to say there are certain choices that we make. And those moments when we make those particular choices, we need to go deeper into those particular elements. And hence, we need to adopt a reframing approach that considers the psychosocial factors and looks at other aspects as confirmatory bias, to say that at the present moment, if I am to ask you about what are the drivers of low uptake of TB amongst men, we are bound to say almost the same things. And all of those aspects, they talk to confirmatory bias, to say that we are biased towards a certain view, and hence we drive our programs towards that particular area, and we decide to design our programs in that particular fashion. But there is a need for us to step back and say, let's talk to the communities. Let the communities talk to each other. let the communities engage amongst each other and come up with interventions themselves that they think would work in the community. Let the communities lead in this design. Let's give civil society to take a leading role in these particular initiatives. And some of these things with us in the health space, you would find that there is an element to do with familiarity bias, where we are familiar with these kinds. In some cases, it's stuff to do with individual life aspirations. So there's a certain direction that we want to take or we want to shape. But if we are to step back and allow communities to take center stage, you would find that we'll be in a position to gather a totally different ideology, a totally different view around what are some of the drivers of HIV, what are some of the drivers of low uptake of TB screening, of linkages to care, and all those aspects. And then we then use that as a means through which communities educate the healthcare workers, communities educate us on how to come up with tailored messaging that we target the communities. Thank you.
Thanks so much, Ndumiso, for those insights. Takalani, I'll hand over to you.
Thank you so much. It's always very hard to be the last one when people people have already commented. But I noted some few things that were concerning to me. I saw low numbers of people on treatment, even if they are detected, and increased loss of follow-up. And I was asking myself, of all the strategies or paradigms that Prof has highlighted, I missed factors around increased loss of follow-up or factors around low numbers of people on treatment. And I saw a lot of strategies, but they are not necessarily addressing the exact factors. So I would concur with all the speakers who said or emphasized that we should intensify community engagement just to get the perspectives of the communities on how we can do this. And I also feel we really need to look at what theories of behavior change say. One that I've identified is the theory of resonant action, as well as the health belief model that emphasizes that people tend to adopt certain healthy behaviors when they think that there is something they're going to benefit from the particular behavior. So what I've seen in other countries, for instance, countries like Asia, Philippines, to be specific, they do incentivize healthy behaviors. So I would like say maybe we also have to look at incentivizing the adoption of healthy lifestyles and behaviors so that we may be able to improve on lost follow-ups and as well as low numbers of people on treatment. Thank you.
Thank you so much for that. And thank you to the panelists for those insights. They're really mind stimulating. They give rise to new conversations that we could start and we could spend the entire day here. I have a few questions that I would like to pose to the panel, but before I do that, I would like to give our keynote speaker, Dr. Ndjeka, a chance that after hearing our panelists and after his excellent presentation, if he has any other further thoughts to share, having heard from our panelists and them sharing their reflections.
Yeah, thank you so much, Chair. No, I'm really excited. I got evidence that I was talking to people who are awake. It's always exciting. Sometimes you write things, you talk, and you talk to yourself. I wasn't talking to myself. So a lot of the comments are really correct. I will include them. In fact, There are a lot of limitations in what you're doing, and those limitations have been identified. For example, issues of poverty, social determinant. How do we do this? We tried in the past. For example, the biggest funders of our activities, our work, are number one, the SA government, which puts 70–80% of the budget. And then you got Global Fund, and then USAID and PEPFAR partners and the other partners in that order. So at some point, one of our partners, Global Fund, put money for nutrition to deal with poverty. It didn't work. You know, as I keep saying, we are very biomedical. When you suggest even the method for establishing guidelines, we want these randomized, double-blinded clinical trials, those who fly if you present them. Now, if you are saying, no, but our people are poor, can we feed them? Very difficult. But even when it works, you don't get reports, you don't get evidence they are working. So I think, but you must continue to say this because the how part is important. We agree this is critical, it has to be done. The health system must be strengthened. Yes, we fully agree with that. And what we're doing is because, I mean, HIV and TB get a lot of funding through international channels. So a lot of these funds are also used to strengthen the system in various ways. We would fund a number of activities. Even the health infrastructure to some extent get funded through your HIV TB grant, but it's not yet enough. We need to really do more because you're right, the biggest challenges we see are not directly linked to HIV or TB. They are challenges of the health system. You know, so even if we do 100% of our homework within the current primary healthcare, for example, and the structures, and I agree with Steve Reed when he says, when he asks whether the community-oriented primary care, the old version, is not an appropriate meeting place to address this gap. I think so. I think this is correct, you know, because we were so sophisticated. We've left our communities behind. You know, people think when you say community medicine, community health, it's low grade. It has to be big. It has to be sophisticated. So this would be a good way to really go back to grassroots level and fix all this. So we really agree with that. The last comment from Takalani about key interventions for reducing loss to follow-up. You're right, you picked up, you are really spot on. A lot of things have been tried. I mean, we say we send SMSs so that they come back. It's not really working very well. We tried many things, but I agree with you, we've not tried incentives. And we do have food parcels distribution. What's happening? You know, so really this for me, and is, I'm not sure. I think we've got to do something about this. You know, we have to find people. We have to link them to care. Incentives like we had a BRICS meeting last year, December, with the folks from all the BRICS countries. They discussed with us how they do this in China, in India. Very exciting. They give patient certificates and all these things. They've planned another BRICS TB network, TB research meeting end of this month in Moscow. We'll hear it again. But, you know, the issue is not whether we agree or disagree. The issue is how do we implement this in South Africa? And I'm excited we're having this discussion, you know, because we know it must happen, but how? How do we reduce loss to follow-up in TB? The problem is, it's not just with TB. COVID showed us that our diabetic patients do not achieve optimal glycemic control. That's why we had a lot of our hypertension patient and diabetic died. So the problem for adherence to treatment is across the entire system. You're diabetic, you're asthmatic, you're epileptic, is key. So if we're trying to just address for TB, it might not work. We've got to look beyond TB, HIV in the entire houses. Let me end there and thank the colleagues. I came to share ideas. I've learned a lot, probably more than I brought, and it's very exciting. Thank you so much.
Thank you, Dr. Ndjeka. I'm now going to, pose a few questions to some of our panel. I'll leave the question for Dr. Ndjeka for a while because he's just spoken, so it gives him time to catch his breath. I want to start with Dr. Tshuma. I really love what you said about, bringing the community in again, getting them involved, and not just at the level of. Sorry about that. I'm going to mute colleagues. And you mentioned, it's pivotal that we have them not just seeking their guidance as we plan interventions, but rather that they become a part of it and that they lead, that civil society leads. So my question for you, Dr. Tshuma, is that what are some of the ethical considerations involving in implementing public health interventions that prioritize community participation and engagement?
Okay. Let me not start off by the ethical aspects. Let me start off by engagement. Community engagement. So there's an aspect to do with the ethical side, talking about it from issues to do with, let's say, consent, issues to do with, like the research side, the academic side, predominantly academic human rights side. But I want to take it from an angle of it being the community, the individual, the person's right to be heard, right to inform decision-making, right to inform the nature of services that they receive, it being there is at this particular stage, there is a dire need for communities to take a central and a leading role in informing health communication. How health is communicated to the communities. The means through which we do that could vary. We could be reaching out to, for example, typically in our case, we do, say, community dialogues where we are having engagements with, let's say, particularly men in the mining community, talking to them about TB, but with a special focus on saying that what makes men not to be screened for TB. And then you engage them on another topic to say, what makes men not to be linked to TB? What makes men not to be retained on TB treatment? And then you begin to understand those particular aspects that are affecting, that are influencing their decision-making process, or the journey that they go through in that particular process from the time when they are making a decision whether they want to be screened or they don't want to be screened. They want to be linked to care or they wouldn't want to be linked to care. And having that in-depth understanding of that particular aspect is key and critical in us determining the nature of interventions that we do. I believe that a blanket approach to healthcare programming, to some extent, is an unethical practice. A blanket approach, to some extent, is an unethical practice because we are exposing people to information that they are not willing to assimilate, and at times it serves as a barrier to them actually moving to the next stage of saying, now I would want to go to a health facility. So hence I start from the point of engagement much more than the ethical part. To say that from my perspective, I feel there's a lot of information that sits with community members, with the communities that we are in. I always give a typical example of myself to say, what are the chances of me going to a health facility, a public health facility, to receive a service? I'm a man. And what are the chances of me doing so? And if I'm to look at other fellow men, I look at them from my own personal perspective. Then I say, what makes me not move that direction of a health facility? And if I'm to meet with someone and then they give me certain information, that information might make me feel like, no. Or it might make me feel like, you know what, I really need to go and seek health services. I really need to adhere to treatment. With the level of sophistication that is there nowadays, the emergence of AI, all the access to information, as healthcare workers, we should be in a position or at a juncture where we are able to communicate effective messaging to the communities, but being informed by those communities. I'll give you typical examples with human-centered design approaches, where you sit with the people, you understand what they need at a community, or they themselves engage amongst each other. You know, of course, observing ethical boundaries, where we'll talk about confidentiality, you know, freedom, and all of those ethical aspects that comes with the research work that we do. But wearing the hat of an implementation science approach, where we are saying that we are collecting this information for purposes of informing program design and program redesign with the communities, where communities take a leading role in giving us the bits and pieces to say, you want to go and screen men. I'm talking about men because I'm a man. You want to go and screen men. This is how you can package your messaging. This is how you can approach them. This will be acceptable on their side. This is the response that you're likely to get. And then we go on to talk to another group of men that have gone through the TB screening, they've gone through TB, and then what brought about that shift or that switch for you to say that I haven't been screened, now I would want to be screened. So once we pitch it with that in mind, I believe that would drive change. And that would be the most ethical practice from the side of us as healthcare workers when it comes to dissemination of health information, where we come up with tailored, targeted health messaging. Hence, I keep on hitting on that pillar number one, the communication aspects and the advocacy aspect, to say it plays a critical role in the manner in which we come up with our targeted messaging to the community. Thank you.
Thanks so much for that. My next question is to Takalani. Takalani, how can interdisciplinary collaborations between the various fields such as medicine, sociology, environmental science, economics, and beyond enhance public health efforts?
Natisha, for that question. Actually, if you have heard Prof. Ndjeka in his definition of public health, you might have seen that public health is interdisciplinary by nature, in the sense that when we say public health, we are referring to sanitation of the environment, and that is environmental science. We will be talking about empowering communities, and that is to take ownership of their own health, and that is health promotion. When we start to look at what is the cost versus benefits, we are now talking economics. So all these fields, actually, public health is very much interdisciplinary. I'm not sure if I have answered. Thanks.
No, you're great. Thank you. Thanks for that, Takalani. My next question is, I know that, Tumelo, you spoke about, vertical structures that we often seem to kind of adhere to, and we need to move away from that. And we've also heard some of the rest of the panel talking about the socio-economic factors, as well as our keynote speaker. My question to you is, how do socio-economic factors influence health outcomes? And how can public health initiatives address disparities in access to healthcare and these health outcomes?
Thank you. I also spoke about the social ills in the communities. We have high poverty levels, we have high crime. Somebody spoke about road accidents, and all these affect health, and they affect the health of the people. And the public sector, the public health sector, often has to respond to these. So just to go back to what I said earlier, in looking at it as a health system and recognizing that health systems are complex and they are characterized by, by emergence, things happen and things change and we have to respond accordingly. It's important to then look at how do we strengthen systems that are within the health systems. And an example here is the community health system. Also referring to what Steve Reed was talking about, how do we strengthen community health systems that benefit our communities, benefit our individuals or patients? We have community health workers within these communities, but how do we include them within these systems, and how do we use them to enhance the community health system? How do we bring the different sectors in to improve the community health system? How do we bring in education? How do we bring in social development? How do we bring in policing? And how do we make them work together and strengthen those networks and understand the networks that exist within communities? We have formal and informal structures within the communities that benefit communities, and that communities also trust in and even believe in more than they believe in the public sector. How do we bring in those sectors to build a community health system that function and benefit the communities, but also function alongside and with the formal public sector? Thanks.
Thanks so much for that, Tumelo. Ishak, my question to you is, we've spoken about two very broad and important areas, which is communication and advocacy. My question to you is, how can technology and innovation be utilized to support and enhance traditional public health approaches?
Thank you so much, Natisha. I mean, I think there's a couple of things for us to be mindful of when it comes to technology. And the first thing is the context in which we are staying in. So, we live in a world where there's so much disparities. And I would just take Cape Town, for example. In some parts of Cape Town, we have people that are building robotics and AI, as one extreme with regards to kind of information and messaging and using that for leveraging behavior change. On the other hand, we have some parts of our communities that struggle to have access to a cell phone. So we live in with these kind of extremes of society. And I would actually come back to what to Dr. Tshuma's kind of point was with regards to community engagement. There isn't a one size fits all. Whatever technological kind of whatever kind of technological innovations we're going to be thinking of needs to be tailored for the communities that we are busy with. So for some communities, where there is no cell phone, we have to think of, how many cell phones are there in the community? How can we leverage? And I think that, for me, the word that comes to mind is Ubuntu approaches, where communities are working with each other for social change. So, for example, one cell phone might be shared by 3 or 4 households. You ask for someone's cell number, they're going to give their neighbor's cell phone number, in order to be communicating with. And then there are obviously issues around confidentiality, in a situation like that. So how do we leverage things in a situation like that. And then we go to another kind of extreme of where we've got technology available for us to make remote diagnosis. So I have the privilege of working with some telehealth groups, and so we kind of, on the one hand, we have access to 5G, and we're busy building algorithms for 5G, but in other aspects, because certain communities don't even have 2G, in terms of cell phone communication. So these are the kind of things. There are ways in which cell phone technology, we saw how with COVID, we were able to kind of help with diagnostics, remote therapeutics with regards to treatment. There are ways in terms of enhancing kind of follow up to a certain degree within limits. But to know that there are many potential solutions we can think of. There are many things that I can't perhaps think of, but a few. I mean, I can maybe get some of my younger colleagues, and I'm sure they'll be able to think of certain things, innovations based on the new things that we've got available. But to bear in mind the context that we're in, and whatever innovations we're thinking of, to realize that there is a great limitation in technology as well, with some promise.
Thanks so much, Ishak, for that. My next question is to our keynote speaker. Dr. Ndjeka, we spoke about paradigms in public health, the existing public health paradigms. My question is, what are the potential barriers to implementing new paradigms in public health, and how can they be overcome?
Yeah, thank you. That's a great question. I think the one challenge we've been really having within government is the fact that we're not implementing old principles well. I mean, the role of a TB service or HIV service is to find people with these conditions and link them to care. So we're really struggling with that. We have a lot of missed cases, but also the way we've been conducting business over the years. If you look at, for example, the Global TB report, you look at global report, you see a lot of countries achieve like 90% cure rate for TB, and then this has been like the key thing. We do it that way. And the other day I was talking to a group of academics in one of the countries. They do very well, and they were surprised that the World Health Organization asked me to talk to them to share my insight on how to handle MDR. They were shocked when they heard that we only treat like 60-70% of our MDR TB successfully, and they treat 90%. Therefore, they should be the one perhaps giving me those lessons. But I told them that unfortunately, you find that they find 20% or 10% of their estimated burden, and they treat them 90%. Now, when I talk about 70% success rate, it is like 70% of my actual load. Now, what is best? 70% of 70% or 90% of 10%? So this has been how services have been designed, programs have been designed, the reporting and everything, creating an idea that you are doing great when you can't even identify, you are missing 90% of people you should be finding. Those are really barriers that made it that it becomes then difficult for you to tell yourself that, yes, it's 90%, but because I've only found half of those I should have been finding, this is 45% in reality. So that kind of thinking has been really a big problem to progress. There've been also this global idea that you only test to find the number you can treat according to the budget, you know. So I remember I conducted the MDR TB workshop in 2010 in India, in Ahmedabad. And I was shocked. As the only person from Africa, from South Africa there, I was talking to people who thought that I was crazy. You know, I told them, no, we are trying to drive a number. We give everybody expert. They say, no, you can't do that. You use microscopy. You use expert to those who have failed regime 2. You know, so these are things that have been happening that prevented us, for example, from achieving maximum result. Now, moving forward becomes very, very difficult. People are so obsessed with the directly observed treatment. They want to bring everybody, every TB patient to a clinic and observe them taking those pills. I say half those guys are people living with HIV. They get their ARVs through CCMDD. Can't you put the TB drugs with the ARVs sent together? You know, it's work in progress. It's still work in progress because I got to first convince all my TB fighters in the country before I do something. You know, so when you deal with very paternalistic ideas, you got to go very, very slow. And for me, those are some of the things that make it very difficult to embrace new ideas, because when you say, can't we give these guys smartphones to remind them to take, you know, I mean, like the MDR guys, we spend so much money on them. They're so few. They're like 3% or I mean, among the new patient, but new TB patient. But if you look globally, like the whole cohort, it could be maybe 7% of the entire cohort. But you spend a hell of a fortune, far more than the rest of the TB patient. I'm like, can't we give them smartphone to remind them? And oh man, they'll steal phones. So this for me is very difficult. You spend time when you bring new ideas. You spend a couple of years trying to convince your healthcare workers that this is a good direction, that we should do this. So for me, these are critical things we got to be dealing with. Civil society need to be helping us. We want a civil society that is neutral, that is helping us, that would take whatever we do and really critique it, not just criticize it, because I understand sometimes it's good to show very bad reports of your country, in some places to get funding, but we want civil society that really brings more contribution, but also implement. But I know that they don't also get much resources. So what you have to do is to make sure that they get more funding. That's why, for example, we told our Global Fund colleagues to say, can you increase the split between TB and HIV? Because the guys do more of HIV. If we increase more money for TB, you get a few guys who only can do HIV work to come to TB side to strengthen, because the two programs need to receive similar attention. So for me, these are really a lot of issues. We really so locked in our old arrangements, and we got to find a way of moving forward. You know, if you say let's give food to our people don't find it a nice conversation. But we've got to find a way. We have to make sure we bring all these aspects to the table, so that we are able to implement program and get the results that we desire. But what's also important, multi-sectoral accountability framework must be implemented. All state departments can do this. We can, if we work together and we're all accountable at some point through our SANAC and Deputy President Office, I'm sure we can be do some of these things. Thank you.
Thank you so much for that. So thank you, panel, for that. I'm now going to go over to our audience. We have some questions. If you could go back to the chat box. Instead of reading them out, I would like to give colleagues in the audience a chance to ask their own questions if they are still available. The first one is by Steve Reed. Steve, you can go ahead if you are in the audience.
Sure, thanks, Natisha. Natisha, I think my question is self-explanatory in the chat, because I feel there is a huge gap. The seminar was entitled, had the word paradigms in the title, and I just think we're in a way working off different pages when you consider that a large part of the health budget is spent on curative health services. And as you say, as somebody said earlier, the public health, the connection to public health is not clear and not well made. And I think it's in this area of paradigms and the ways that we think about clinical medicine, clinical care versus a public health approach. I just think we need joint thinking, or we need one paradigm to address the challenges of health in the next period. So yeah, I don't want to add more to what I've written.
Thank you so much for those insights. It's really appreciated. The next one is, if I can ask Caro Smith to please unmute, and you can go ahead with the question you've put into the chat box. Is Caro still with us? No, I don't think so. Am I correct in saying Caro is not available? I'm happy to read the question out for panelists. The question reads, please can I ask why road traffic accidents or crashes are so underrated, and what can we do about this? Road traffic injury is a public health issue. And they go on to reveal that the health sector is an important partner in the process of prevention and control of RTA, but the role of medical professionals in advocacy for prevention and control is always underrated. I'm happy for any of the panelists to answer this.
I can address it, Natisha.
Sure, please go ahead.
Yeah, so I think it's a very good point, right? And once again, we go to the question of why are road traffic accidents such a huge issue, and one of the big determinants is substance abuse, alcohol. And so there are public health specialists and involved in advocacy around alcohol legislation. But it's a big challenge. So once again, we've got certain things we're doing from a top-down approach, but coming back to what Dr. Tshuma was speaking about is how are we getting communities to be engaged, to think of what are the solutions at a community level with regards to dealing with challenges around road traffic accidents and alcohol, and changing things at that level. So there are things that are being done, but not enough. And all of these things are really interrelated. There's a big kind of you can see, you have to ask, we have to do the why question in terms of coming down to it. So we have to ask ourselves, why are people using alcohol? Why is it such a big challenge? So we find that in many of our communities, we have an alcohol economy, where that is kind of the main source by which money comes into the location. And so, how do we address things from that perspective? And just, tying back to what was said before about, the need for intersectoral approaches and how we can be used to kind of address it. I just want to make one further point on that. You know, we do have, it's always a question of not enough money. And so, you know, we have, for example, a alcohol levy, where money goes to government. Government taxes alcohol and smoking, but that money is not redirected towards health. Now imagine we could use that money to pay social workers to be involved with kind of intersectoral approaches within communities. Then we can do a lot. Also, the other thing to say is that, you know, we often, when we're thinking about these things, we think about new interventions to deal with issues, but actually all we're needing are whole of society approaches. So if, for example, the Department of Road Traffic, you know, was speaking to the Department of Health and speaking to the Department of Social Health, and we have groups that are focused on communities at a local level, with communities, you know, looking at social upliftment and dealing with all these issues. You know, when we are dealing with issues around road traffic accidents, the person that is Department of Traffic and Policing comes into the meeting and says, you know, we have this challenge. Our incidence, our prevalence of road traffic accidents is coming up quite high. What can we do about this as a community? And so, as an intersectoral community forum, we can then potentially deal with these issues.
Thanks so much, Ishak. Before I go to the two colleagues in the audience who have their hands raised, there is a comment for us. This comes from Sheena Lot, who says there are systems that work well in some areas and not in others. There are also war rooms, and under the OSS Operation Sukumasaki for KZN, the issue with that is that to get these to work in the wards, the KZN Department of Health is currently working towards making them work and will be training them to address health promotion activities at a ward level. Thank you for the comment. I'm now going to hand over for the first question to be asked. Krishna, you can go ahead. And do let us know if you would like to post the question to any particular panelist as well.
Thanks very much, Natisha. Can you hear me?
Yes, please go ahead.
So first of all, let me say congratulations to PHASA on arranging this series of webinars. I think the topics are highly relevant, and it's a very useful thing to do, to create this kind of opportunity to reflect and just share ideas and to learn from each other. And I think well done to PHASA in organizing this week's of webinars. I just want to make two sets of remarks. The first one is, I think, you know, as a health system, as a health service, we kind of see our core business as health service delivery, right? And like Steve and others have intimated, I think that leads us down a path of highly curative, individualized focus, right, on patient care. And we as public health fraternity and practitioners have the huge responsibility of trying to shift the focus to population health. And that's all of public health plus a health, more holistic health systems approach. I think we don't do enough of that, and we have to try and steer the health system and health leaders to become stewards that speak up for the intersectorial determinants that impact on health, right? And I think we don't do enough in that regard. And that really, you know, that responsibility and that initiative, I think we should embrace as a public health fraternity. It also is not an easy space because it requires courage and activism. And I think the South African government on the Gaza genocide issue has led a sterling example of that. But we as public health practitioners have to speak more vociferously and aggressively on the issue of social determinants. Now, I think that's an old age principle, and I think every public health person knows that. The issue is in practice, and how do we do that, right? And I think we need to apply our minds to being more creative in the how. And that is whether, you know, how we become better advocates in the intersectorial space, whether it's poverty, whether it's violence, whether it's road traffic accidents, water, sanitation, and the list is endless. Whether it's how we engage communities to design services. I think one of the speakers spoke about that. But the question is, how does one do that? Having been in government for many years, I think also as a health department, we don't advocate internally within government, right, on some of the intersectorial issues. So we often see climate change as a policy that is in the environmental health department, or we see poverty in the economics department or social development department, and we just continue kind of inwardly focusing on health service delivery. So I think this issue of paradigms and how we apply ourselves in practice is a big issue, and well done to focus on this. But the question is on the practical aspects of the how that I think we need to think harder about. Thank you very much.
Thank you so much for that insightfulness. It's really engaging, and it can stem to new discussions. Thank you very much. Our next person from the audience who has a question or comment, Nonsikolelo Mapukata, please go ahead.
Thanks, Natisha, and thanks, colleagues, and thanks to Dr. Ndjeka for that lovely presentation. So I come from a rural area, and in the little while I've been going home a lot. And I mean, going home has previously been an experience, that brought much joy. That has changed. And why it has changed, it's because there's a lot of alcoholism. And perhaps not necessarily in my community, but I know that in some communities, drug abuse is also an issue. And with that, there's violence, a lot of it, and there's crime. So when we thinking about public health and thinking about what should be our priorities, I'm beginning to wonder if we need to rethink what we qualify as our big five. Because I mean, a lot has changed. Behaviors are out of control, and if you're looking at who is affected, it's mostly young people and middle-aged people, and those are supposed to be the people who contribute the most to society. And so the question that I have in my mind is, to what extent is joblessness impacting TB and HIV outcomes? Because I mean, if somebody is drunk most of the time, they're going to default on their treatment. We're going to have compliance issues. And we know that ultimately, one is going to end up with multi-drug-resistant TB and other ills. So my question is, so I teach first years here at UCT, and we talk about multi-stakeholder engagement, so we try and, I try and talk to them about, the common issues that affect people of their age group. And so I'm wondering if we're talking about, who should be partnering with the Department of Health, to communicate messages. Is it now going to be SAB? Should we be looking into that? Because they're doing a great job. I mean, they are successful, and they have always been successful. I remember way back when we had the public health strike, the only thing that was delivered was alcohol. And I was still at VETS then. I was working with final years, and they were saying that in some communities, as you drive through the community, the only messages that you see on the billboards are messages about alcohol. So then, it brings me back to our priorities. Who should we be talking to? Who should we invite to be our partners? Are we going into churches, for instance, in some communities? So I think Dr. Tshuma did speak to the fact that we cannot have this model that is a one-size-fits-all. We need to be looking at what is needed in communities and tailor our strategies to suit that. And I know that, as I said before, the structures, the traditional leaders, they no longer have that clout that they have. Well, I suppose maybe if you go to KZN, that might be a different scenario. But where I come from, they really have lost their power, which means they're no longer effective in their communities. And we are in this phase now where we are looking forward to voting on the 29th of May. But when you listen to the politicians, they're not talking about the priorities in particular areas. They're not talking about TB. You know, they're talking about other things, you know, that are related to politics, but that do not meet the needs of the communities and the needs of the constituencies. So my question then to Dr. Ndjeka is, how I mean, have they considered restructuring their approach and also inviting a different set of partners to the table? Because I mean, what we're doing now is obviously not effective. Thank you.
Dr. Ndjeka, you can go ahead.
All right, thank you, Chair. Yeah, no, thanks a lot for that great question. You're right. We really have a big problem here. What are the priorities? What are we doing to restructure the approach? So, like I indicated earlier on, a lot of the basics are not yet really in place. You know, finding people, we still have a lot of missing people. We still have challenges to link them to care, retention in care. So if you look at our NSP, if you look at our strategic plan for TB, there are a lot of interventions there. We talk about TB vaccines and all these dashboards that can be accessed by communities so that they know what's happening and interact with us. Unfortunately, it is difficult to really move past to those because we're still battling with a lot of things that we should have done well, you know, 10, 20 years ago. I've seen a message, a comment from KZN where certain things are done well in some areas and not done in other areas. We're also battling with the issue of variable performance from staff members within the same unit or in different districts, which create problems. And you find that processes to really ensure that people who don't perform account for that take long time, and all those things are challenges that we have. One of the things that we are thinking of from government, from TB particularly, is the improvement of the community-led monitoring. This is happening, but the way it is happening, you'll hear when a minister is visiting, because I do a lot of those. We go with minister somewhere, they invite him for a coffee, and then they give a list of all the wrong things that are happening. It's okay, but I think if we do, I've seen in other countries, your community-led monitoring, you got people on the ground who are constantly monitoring those problems that our minister get given because it's World TB Day commemoration and all this. Those things go to people at district level, people at facility level, to say TB patients are running short of drugs. What are you doing? You know, and this is get documented so that we get a report which is saying the district can't help, the province has been unable, we've been doing this, can you come in here? So we have a community-led monitoring that is done differently. So this is something we need to strengthen so that there should be more organizations that are monitoring, and then they must report, you know, timely to government, and then we give responses. But the other thing is within SANAC, we have civil society represented. We have a TB working group within SANAC, and I think we need to make sure that this structure is more active, because you got private sector, you got civil society, everybody within SANAC and government. So if we accelerate, we need to review perhaps our terms of reference. I'm sure that should be a better way to begin to tackle this problem, but we must also ensure that the people who support healthcare services should fund civil society as well, so that there's more funds to support. That will be able to restructure this, working more with SANAC, involving our communities, more in what we do. I know that is not happening a lot. We should be inviting them when we revise guidelines, when we do everything. We invite them sometimes, we don't invite them sometimes. So I'm sure through SANAC we can strengthen this, and that's really what I can say for now. Thank you.
Thank you so much. And I think we're almost at the end of the time. I do see hands up, but we need to also keep to time. I did have one comment from Hazel Mashlanze, which I will very quickly read before I summarize. And she talks about maybe we need to go back to basics because of the inequality that exists in our society, and that we need foot soldiers to disseminate information. There are so many unemployed health workers. And so she talks about, we need to have priorities. The country has demonstrated how much and to what extent they can go for screening during COVID, and we need to retain those mechanisms. There are a few other comments. Please quickly, you can read through them. Thank you once again to Dr. Ndjeka for that amazing presentation that set the scene for today. To our panelists, Dr. Tshuma, Tumelo, Takalani and Ishak, I want to thank you as well for making time for this important session that kick-started off our week that PHASA has lined up. Some of the discussions from today are definitely going to lead on to the discussions that are going to take place tomorrow and the rest of the week. Please do join us for those sessions, but thank you, colleagues, for that. Thank you to our wonderful audience for taking the time out of your workday to stay with us during this insightful sessions. And please do join tomorrow for the next session. As I said, each session streamlines into the next. Very thought-provoking sessions. Very quickly to summarize before I end, is that it was a commonality amongst our keynote speaker, our panelists, our audience, all of us saying the same thing. We cannot address public health if we are looking at it with one blanket effect. It's multidimensional. We need to look at it at various structural levels. We need to look at the interplay of stakeholders. We need to look at advocacy. We need to look at communication. And with those as well are not just one layer, but several layers that focus and come into a common theme of how we look at realigning and rethinking the paradigms that we would like to work in. I want to thank you all for today, and I look forward to engaging with you tomorrow. Thank you.
Thank you.
Thank you very much.
Thanks a lot.
Thank you. Bye-bye.
Thank you.
Thank you.
Greetings, everybody.
Bye.
Bye.